in 2023. But what you will also see that we don't have a lot of level of evidence A, and only a few with B, and that will going down because the rules of the ESC are much stronger now, and we could only enter that at that certain level, and that is in some countries then similar to a certain law, if we have prospective outcome trials, and that is difficult. You already said we are images, so we have to share images, but it's not only about sharing the images alone, because we have to make just a fence, and we want to we really want to handle the patients finally. But when you go into all the indications, and you realize that, and that was before the 2024 guidelines, that there is a major impact on indications regarding cardiomyopathies. And it's also just about general myocardial tissue differentiation. And what one should know that we once analyzed, these are all those sites having really unproblematic access to CMR. They are also running a lot of assessment of coronary artery disease. Because all of us know when you just want to go towards coronary artery disease, one also could use SPECT or stress echo or whatever. But regarding cardiomyopathies or inflammatory diseases, that is a unique identifier of CMR. So it's somehow, not somehow, it is accepted, it is needed in clinical routine. All of you know, or some of you may know, that we have that we have problems worldwide with the reimbursement. I guess it's different in Switzerland. In Germany, we have huge struggle there. The good thing is that there is no need, I hope it, I assume it, to explain you all the techniques we have. And already with a straightforward CME imaging, we are able to differentiate, to identify certain abnormalities. Meanwhile, as you see here in the line above, we were also able to scan without any problems, just active devices, in that case, a pacemaker, MR conditional pacemaker. We have real-time images. One could really not only make a Valsalva just to identify, for instance, a constriction versus a restriction. We are able to go into myocardial tissue differentiation, like in that case with that small dots, visualizing a myocarditis. One could, on top, is strain-like identification of deformation images and other possibilities like here for the flow. I would say currently already routine in, for instance, congenital heart disease, but for certain reasons, one could discuss it a lot, currently not, also due to the accuracy in usual CMR. All what we want to do, and I already mentioned it, is of course to put forward a diagnosis, change our uncertainties, want just to make a prognostic impact to guide the therapy, but we also have to be really efficient, that it does not take such a lot of time, and it's a lot about precision. So if you want to scan a patient twice, next day, for instance, or a healthy volunteer, one should get the same result. And believe me, that's not the case with all sequences, with all the post-processing software. There are a lot of influencing factors, not only in cardiomyopathies, but due to the fact that especially in cardiomyopathies, we tend to quantify a lot of myocardial tissue properties. There is a huge need to be precise. And if one talks or is talking just about quantification, we can quantify a lot, similar to echo. More than that, we put it forward. But whatever we are doing, I'm convinced we could scan every patient 1 hour plus. But finally, if we don't do research in a moment, but just have a clinical question, then it needs a clinical answer, because that is just the consequence. And there we need a precise quantification. The reason why I'm repeating it all the time, because I know the differences, and I know that especially cardiologists, we are really driven by numbers, troponin, NT-proBNP. So the people believe in numbers, but as all of you know, finally, magnetic resonance is not a metrology instrument, and our numbers, our quantitative results are influenced a lot by techniques, by conscious media amount, and by post-processing softwares. And we just have to be aware of those challenges. And that challenges, they pop up at every time point of the imaging chain. And one cannot so much influence the patient you get. We also have sick patients, but post-processing, annotations, and handling of artifacts, that is something we could handle. And all of that, that is just influencing our final parameters. Probably you think about why I'm talking about that so much, but when I walk through the cardiomyopathies, hopefully your thoughts will come back to that. And that was really a bit a game changer when in 2023, it was published. The cardiomyopathy guidelines were published. And what was a game changer that already in the central illustration, the phenotypes were in. One could just now start to discuss, does it make a lot of sense to go back to arrhythmogenic right ventricular cardiomyopathy? Should we stay with arrhythmogenic cardiomyopathy? There are plus and minus. Does it make sense to raise the awareness regarding non-dilated left ventricular cardiomyopathies? We could discuss it, but that is not just the aim of the talk. And finally, this guidance is here just now. And the idea, and we discussed it a lot of them with the first and the last author, so the chairpersons, was that you are just opening a door saying, be aware of it. That can be a cardiomyopathy. It is extremely important just to run CMR there. And it was Perry Elliott some weeks ago saying at the meeting of the European Working Group of Myocardial and Pericardial Diseases, there is also a certain impact or just a certain discussion on endomyocardial biopsies and of course genetics, both important. But he really said, come over it. In every patient, you have a suspicion of a cardiomyopathy as well as the relatives. You need a CMR. That was really a significant word. Perry is very experienced in cardiomyopathies. He's not primarily imager, but extremely open-minded to that. But never mind, what will happen probably with that guidelines, and here we have to have the awareness. Of course, we know not all of the HCMs have a late gut here. Not all of the DCMs have a late gut here. And there may also be a dilated cardiomyopathies HCM without any late gut, and so on and so on. So these are examples. It's about raising the awareness, and finally, imaging is a part of the whole decision making. But the impact is increasing. What one is needed, to my opinion, and that word, and I love it, it's not from myself, cardiomyopathy mindset. When you have just an atypical image, you don't know what it is, then think about a cardiomyopathy, open your mind. The diseases, they just have a certain time course of development. You may have a hypertrophic cardiomyopathy, and there's only a mild hypertrophy, but it may grow over the time. So when you think about cardiomyopathies, you really have to evaluate just all. What about the valves? What about the insertion of the papillary muscle? So phenotyping cardiomyopathies, that is not only plus minus, and that makes it so amazing. On the other hand, typical phenotype of a dilated cardiomyopathy, often they are not able to hold the breath. And that is just the compressed sensing, free breathing sequences. I love new sequences. And I know, as you as well, you love to drive new developments. But every time when you get a new sequence, one also has to check, are the numbers regarding ejection fraction, regarding the mass, are they similar to those you got with other sequences? The spatial resolution may be different, as well as the temporal resolution. Here with compressed sensing, it was working fine. Others, and we as well, we have proven it. But of course, it's amazing when you really get images like that without any breath hold. But as I already said, it's not about function only. You could also get it by echocardiography. What makes a difference, for instance, especially in those guidelines just headed by the electrophysiologist, and I had the honor to be a part of that group. And believe me, I was often the one saying, please stop it. The CMR is not at that place already, but you have the impression and you feel it and you learn it that the electrophysiologists, other cardiologists really need that guidance. And what happens here is that, for instance, in dilated cardiomyopathy, we have LGE should be considered, and 2A is a lot. In dilated cardiomyopathies, non-dilated cardiomyopathies, for assessing the etiology and the risk of ventricular arrhythmia and sudden cardiac death. And that's just about LGE. And more than that, and that was a large discussion, a long discussion, ICD implantation should be considered in the diseases in patients with ejection fraction less than 50 and more than 2 risk factors. And one of the risk factors is the LGE on CMR. I know that a lot of people say, hey, why not making it much more strong? Because we don't have the outcome trials currently. Really, the outcome trials, meaning the studies were at first really powered on that. But we have first trials, and so it's at least 2A. And we may also have that one could say that is a phenotype of a DCM, but one should also think about that it's really not a usual wall, right? Septal wall here, and that was a young female with a pulmonary sarcoidosis. But sometimes, you know, the decision making, the reporting is done very fast, and then it could happen that it's just a DCM. But that's about the cardiomyopathy mindset. Think about the walls. And sarcoid, of course, you know, as all of you know, that is a huge trouble. It's a chameleon, that disease that may mimic not only a dilated cardiomyopathy. Sarcoid patients may have a normal function, may mimic a restrictive cardiomyopathy, as well as the HCM. In that case, significant late gadolinium enhancement, and also just on the whole wall. What happens in sarcoid again? You know, here in the arrhythmia guidelines, they put down in patients with sarcoidosis, cardiac sarcoidosis, ejection fraction more than 35%, but significant LGE at CMR after resolution of acute inflammation. That's extremely important. ICD implantation could be considered. What the hell is significant LGE? But we did not have data. And I will come later on just to quantifying it. And resolution of acute inflammation, all of you know that it's not always straightforward to say it's active or not. And it's also not the case in PET that it's always correct. So one has to put it together, and again, being aware of the confounders, and really just put forward a reliable MRI. And here again, in patients with cardiac sarcoidosis who have an ejection fraction between 35 and 50%, and a minor LGE at CMR after resolution of acute inflammation, one should think about electrophysiology stimulation. Inflammatory diseases, I could go on. And 4 years ago, in the sports guidelines, and not only just for athletes, they put forward one can go back to sports if there is no ongoing evidence of inflammation or myocardial fibrosis. That's an issue. Because if you have a myocardial fibrosis in the beginning of a myocarditis and following those guidelines, even if it's a small one, you could not bring them back to sports. Is it right? We don't have the data. It's expert level C. And of course, one can understand the experts. And I know and I'm convinced there's a lot of discussions, but there we have a lot to do in CMR. I will not go into the details of detection of inflammation. I put myocarditis, the word myocarditis in too, but I always love to say it's about inflammatory reaction, because the same protocol you have in myocardial involvement in systemic disorders, you may have it in a phenotype of an inflammatory cardiomyopathy, and one have to put the pieces together. But whatever one is doing, most important is, and I know that we once published that 2 of 3, but 2 of 3 is not always possible, because thankfully patients with a preserved ejection fraction and myocarditis, 40%, they don't have scar. And for instance, T1 mapping and T2 mapping, there is a certain overlap just in the message. But most important is, you remember that the inflammatory reaction has to be gone. so just resolved. That means you have to run T2 imaging. Whatever you are doing, T2 imaging, for instance, based on T2 weighted images, or just like in that case, and sorry, I don't have a color bar here but believe in me, T2 mapping, you can just get the numbers or the signs out of it. Both have plus and minus. I know that all of us love mapping, but also mapping in case of arrhythmias or very thin walls can lead you in the wrong direction. So be critical about it, but same is true for T2 weighted images. If someone, for instance, has a very high heart rate or pericardial effusion, you may fail. But more than that, also go for the pericardial affection, for instance, when you run especially T2 weighted images. I want to focus a bit on post-processing and on annotation. But before that, when talking about mapping, you know, all of you, that it's somehow crazy. It's true for T2, it's true for T1 mapping values. They depend on the type of scanner, on the field strength, on the type of sequence, vendor, and so on. But also probably post-processing. But is it really possible? Is it realistic? Does it make a method more safe, more reliable? If everyone has to establish own normal values, it's an issue. So how to handle that? Of course, no doubt, the most safest way, and that is putting down in that consensus document, and that is the best what we currently have, that yes, one has to go into that. I'm convinced, and that was also significant discussion there, if one has just a leading site with having the same sequence, the same scanner, the same post-processing software, one could really share the normal values. But again, that's an issue. We once did the following, that we had healthy traveling volunteers, that is Berlin, different scanner types, and they traveled from one scanner to the other. And we really run T1 mapping, T2 mapping, also for the flow, all what we could get just to understand where the differences are. Here, you just have the numbers, in that case of global T1, was the same with T2, by the way. And there were differences, but they stayed within a tolerance range at 3T. Of course, 1.5T different. That's not surprising. But here we really standardized the sequences. You see here differences, but again, that was published a lot. You have it also if two different artificial intelligence solutions, two different readers identifying something, but that was a tolerance range. So it is working with standardization. That is again the tolerance range, and it was in between. Here's a certain bias in, we could discuss it long, but it was working. Never mind. It would be bad if we would say standardization is the only solution. On the other hand, we need mapping because it's not realistic. We are lucky ones in our, in our field. We have amazing scientists in. They're always developing new techniques, new post-processing. That's amazing, but we get different numbers. So is there probably a different way? There are some approaches published. I guess they are not there for clinical routine, but I always try, and that's the reason why I put it in here, to convince people to work on that. So once it was published by Daniel Misrogli at that time, first author Kranzusch, that there were traveling patients and traveling volunteers with amyloidosis and healthy ones. And you know, the numbers between Siemens, GE, Philips were different, but after using the so-called Z-score, it was working. I know that there are problems, but there is a chance. We started a proof of concept. The code is published. We would share it if someone would love to go on with those development. A different way that I said, I want to have a database. One is putting all T1 mapping in, and just a normalization is coming out. Probably one could not name it T1 mapping anymore. It's just a T whatever, but it gives me information about that, what we expect to get from T1 mapping. And Darian from our group published Marissa. We have a lot of funny names in our group for our approaches. And he put a lot of data in just from Siemens and Philips, and also different T1 mapping sequences. And what it turned out, that after the standardization, so that is before standardization, healthy volunteers, HCM amyloidosis, you see here differences. Then he put a normalization forward and it worked out. I was extremely afraid in the beginning when we run a normalization that I cannot differentiate anymore between diseases and healthy volunteers, but it worked. It's the first attempt, only some different sequences, only 2 different vendors, but there's probably a way how to go. Never mind, I'm the last, blaming mapping. I'm totally convinced that we need it. And in that group, I guess there is no need to convince you that it helps us to identify also fibrosis like here in HCM. I'm looking forward to the publication of the HCMR study and hope that T1 mapping will also impact the identification of risk in those patients. And there's also no need to convince you that it's extremely helpful, for instance, for amyloidosis, Fabry. So we need it, no doubt, but we should also go on to work on this. Cardiomyopathy mindset. I really assume, and we don't have it published, but we think that we can close the database this year, that the largest HCM registry, international one, can give some information about outcome of those patients. The good message is the patients did not die early enough, and I'm happy about that. So it was hard to get the outcome data. Never mind, nearly 3,000 patients from 6 different countries were included, and just genetic differentiation and also other findings were analyzed. Interestingly, those ones without a sarcomeric mutation, they had much more often, really, for instance, left ventricular outflow tract obstruction. That's interesting. So left ventricular outflow tract obstruction is probably not relevant just for outcome regarding arrhythmias, but we have to wait for the results. It was also published that we have different phenotypes, and never forget, it will change over the time. It may change over the time. So you may have in young adults really a very mild hypertrophy and only eccentric, like down here, and it may develop over the time. But HCM also was included really a significant percentage in the arrhythmia guidelines. Like here, it's recommended in all patients for a diagnostic workup, for instance, also to differentiate amyloidosis, like here, and also just for risk stratification. And that got me crazy, believe me, because here you have it. ICD implantation should be considered in HCM patient aged 16 years plus, with an intermediate risk based on the ESC risk calculator between 4 and 6, with a significant LGE at CMR. And here we have a number, 15% of LV mass or ejection fraction and others. Why did it get me crazy? Because that was one publication it was based on, and the 15% have a lot of influencing factors. That is the reason for that usually. But it's just in there, and I know that worldwide the people are asked for those 15%. But if you get that number out, one has to make it in the same way like that group did it. That means using the similar contrast media, the similar dose of this contrast media, and using the same post-processing approach like they did, 6 standard deviation, double dose of contrast media with the usual relaxivity. So that's an issue. What is also in there, that the apical aneurysm would maybe easily missed in patients, especially with echocardiography, as a part of the risk stratification. There is no doubt that every one of you knows how to quantify your LGE and that we have a full coverage, but all of you know as well that there are different types, and what to include here. Is that still LGE? There is a gray zone. And again, that is highly influenced by different measures. Here is an example that here we once investigated different contrast media, and we had to show that the quantification of the size of the LGE area was different That contrast media had a higher relaxivity, and that has a lower relaxivity. Furthermore, also the timing had a certain impact. So again, standardize it. Another group 2 years ago published an amazing work. I don't know if you are aware of that. They have shown that depending on the location of the remote myocardium you are using, depending on the size of the remote region of interest you are using, and of course, depending on the standard deviation, you are highly influencing the size of LGE, and that is infarct, and infarct is much easier to delineate. And of course, you have all the points of signal variability. So if you go forward to quantify that famous 15%, be careful what you are doing. And again, there's a huge need here to standardize the quantification. And I guess especially you should know it, sorry, it's somehow not running anymore. You remember that once we had the naming of the isolated left ventricular non-compaction. There was a change, and that is also a part in the cardiomyopathy guidelines, that it was realized that for sure there are some patients, they have it as a congenital disease. But there's a huge overlap with other cardiomyopathies, and so the name is different now. And the good point is that if you just have to put just a risk stratification forward, that is equivalent to DCM. And the last jump I want to make to sarcoid, because I've already named it just mimicking DCM, but here it may also mimic just HCM, and more than that, look at the right ventricle. It's published not from the CMR community a long time ago, that sarcoid may mimic a right ventricular arrhythmogenic cardiomyopathy. And that is the other cardiomyopathy. I'm sure you get a lot of requests, and it's easy to identify cases like that should be hopefully also be diagnosed by echocardiography. But we are also often asked, you know this, for instance, for the tissue differentiation of the right ventricle, and their fat is bright and scar as well. And there is my hope, and that is really that I think we need new insights, and we get new insights. Here is a patient with some wall motion abnormalities in the axial image, in a kind of for chamber view. Here you have the axial image, and when you go into tissue differentiation, we use a lot, that's a work in progress sequence. I guess it will be product soon. That is a really 3D sequence, has an isotopic resolution of 1.3 and has had a differentiation between late gut and fat. And here you see that white spots, the fat images. You can nicely see that there is not only just scar, but really fat in it. And I will not go into the details, but that will probably at a certain time point change the criteria for arrhythmogenic cardiomyopathy, right ventricular one, left ventricular one. And I know that the cardiomyopathy guidelines of the ESC, we have again the wording right ventricular, but please be aware that in nearly 40% of the patients, and especially in young ones, one may have involvement of the left ventricle too. So what I want to share with you, and one of my group being very active in the quality assurance, he put a Harry Potter-like story forward. A lot of our projects are named around Harry Potter. So we don't have the chance to be like Harry Potter to solve all the problems in one moment from one second to the others, but we can be aware of that. And that is what I want to share with you. CMR imaging chain is not only nice images, be aware of the confounders, and I'm convinced when one has on top the cardiomyopathy mindset, that CMR has a lot of impact and may change really a patient's outcome. That's my amazing team. I thank, like always, them, and of course you. Thanks for following me.
Thank you, Jeanette. I hope one can hear me now. Please excuse that I wasn't available at the beginning, so the IT left me down. But it was a pleasure listening to your presentation. It was just lovely. And especially I loved your sentence about the cardiomyopathy mindset. So we really need to be aware of those cardiomyopathies, and CMR can give us really some deeper information. But also, I really like that you said that we need to be careful with what we are doing, right? So we can see a lot of nice information, but we can also produce a lot of bullshit sometimes. Sorry for this word. So yeah, so I see a lot of questions in the chat. So usually we do it like this, that I read them, and then you have the chance to ask. So let's see what's there. So the first question is, what role could metabolic substrates play in the marking or detecting of subtle early inflammation? I think it's a tough one, especially, what was it? So it jumped, I'm sorry. Question is so long. Especially in cases where we have like sarcoidosis or other cardiomyopathies. Is there any metabolic imaging possible?
Thank you so much. You know, when I started CMR, I went into that because I wanted to do metabolic imaging. And then at 1.0 Tesla, I learned it does not make any sense, and went back into imaging. I would assume it could work also with CMR, but I would assume, be not specific. It may be sensitive, but it's not there. When you think about PET, of course, that is about multimodality imaging, that it makes a lot of sense, especially in sarcoid, to add it there. But I don't know how it is in Switzerland. We are suffering a lot, and I also learned it worldwide, just that the preparation is often not well done. And if the preparation of the patient is not well done before just the inflammation scan, it does not make any sense. I guess that is true for all kinds, also for myocarditis. I know that something is published there. It's not systematic, but do you know what I think is? It really depends on the patient. You know, we have some patients like with arrhythmia, the other stuff, what is difficult in our case, and PET could probably help, and vice versa. But again, you get also crazy answers by this, and yeah. Yes, we have 7 Tesla experience, and believe me, at the current time point, you don't have reliable images there regarding inflammatory imaging in the heart. You know, as a scientist, so the physicists are working a lot on getting homogeneous images. All those things, we really think it's straightforward to get a homogeneous, really CME. It's extremely hard to get it. On the other hand, I also think when one is going into a focused area there at 7 Tesla, that could work. But that will need a lot of interaction really between physicists and a clinician. Yeah. And there is a second part, right?
Yeah, it's very long. I think in summary, the person wants to know if there are maybe machine learning or machine deep learning algorithm can help in the quantification of LGE, or maybe can solve the issues we have with the different acquisitions and contrast schemes and whatsoever.
I think so, but it's also not straightforward. At first, it was a very interesting discussion at ESC. To my opinion, there are some obstacles we should and we have to overcome. The first is that often the databases machine learning algorithms are trained on, they are not really good cleaned. That's extremely important. That needs some feedback. The second is, I'm totally convinced that machine learning approaches may, for instance, adapt the signal. So if you just now, for instance, have a contrast media with a lower relaxivity, then one could somehow normalize it. To that one, you make your standardization. For sure, that should work, but it's a lot of work. So there is a certain input needed. I'm totally convinced that we could have tomorrow already a lot of amazing abstracts for ISMRM and SCMR. I'm totally convinced. But probably you know Kammerländer, Andreas. Andreas was really frustrated as ESC when he really talked about some databases he got, and he was happy about it in US, and then he had to learn that they were just not clean. So I think it's not, the problem is not, hopefully, to use a unit or a CNN or whatever. And the next story is, and that was something I provoked my data scientists, saying, I believe that different machine learning algorithms will give us different results. And that was only about LV and RV function. And of course it was the case, they are also only human. That means they struggled a lot with the basal slice. I don't want to blame it. I only want to say we have to be aware of it. And I'm a believer in machine learning. We only have to be careful because finally we make a decision, a clinical decision.
Yeah, I absolutely agree on this. So it's very important what is the input and how the machine was trained on what data. If it was trained on CREP data, most likely will give us CREP data as well. So yeah, and all the sequences and resolution and everything actually comes into account. There's another one. When it comes to ischemic cardiomyopathy with an LGE of more than 50% of the myocardial wall, but still the overall EF is above 35. Will CMR change this approach in regards to ICD implantation?
I hope so much. And again, here, the prospective trials are missing for that outcome. I'm totally convinced that you're right. And Ingo Eite from Lübeck in Germany, about, our group, DZHK, you will not know it, that's the German Cardiovascular Research Network. There they are pushing a trial. So that trial is running. I'm totally convinced, but it's not the case today. But what I want to share with you just now, you put it forward how it's published. If I may provocative again, you say more than 50% of the myocardial wall. What does it say? How much of the heart is involved? I know that we need it for publication. I'm against that segments. Because if you say 2 segments are involved, but there's a huge difference if it's 100% of those segments or only 50% of those segments. So it's about also describing the heart as a whole. And I guess that will be extremely interesting, but finally, you are totally right. The amount of scar will help us to make a better differentiation. I'm totally convinced.
Thank you very much. Are there any other questions? No, they were just compliments. So we have compliments from Bangladesh, I see, and also from other people. Atem, do you have anything you would like to add?
No, basically nothing to add. Just wanted to perhaps reinforce what you said about standardization and the differences, and that we have always to be careful. It's not only in MR but also in CT, perhaps to a lesser degree, but it's everywhere the same. Be careful when you measure something. You cannot translate one number from one scanner to the other and from one reconstruction to the other. There are so many differences in data processing, in data acquisition, in reconstruction filters that we are not aware of as doctors. We just use it, and we should really be careful when just claiming numbers and thresholds and as the truth. So we should be careful.
Thanks a lot. Do you know what I think? Sometimes probably we should push it by the societies. If you think about a normal lab just analyzing blood, they have a quality assurance process, a prospective one. They are always running a gold standard. Of course, it's hard to establish a gold standard, but something like that we should do. We once did it retrospectively in 20,000 data sets and only based on the numbers. And we had to realize, and we did not know why, that in 2012, we had somehow a jump in the stroke volume. And what happens was that the post-processing company we used, they changed the formula a bit.
Yeah.
And they,
Yep.
I assume they didn't tell you.
Where do you know it from?
Yeah. This is these are all things that are scary, basically.
Yeah.
But
Yeah,
this fits
so
to
right.
today. I mean, it fits to the date today, Halloween.
Oh yeah, right.
There is another question, I think, in the chat. To what degree can the expertise of the CMR reporter affect the accuracy of the reported findings?
Yeah, of course. Thanks for asking that. Of course, you are totally right. That makes that has an impact. On the other hand, we have the experience that if there is really a structured education, a structured training, also really young colleagues are able to report at least straightforward straightforward scans. And of course, one should make that possible there. What I think is one here again has to increase the awareness that it needs a certain mindset if something is not straightforward. But that is not only about CMR. Think about echo, think about CT, think about CAF, think about taking a history and making a physical examination. It's all about the degree of expertise. It's always the case. It's just about medicine.
Okay. Okay, Robert, then you want to close?
Yes, I'm happy to close this session. So again, Jeanette, it was really a pleasure having you with us and also your sharing your insights and your experience with us.